Right. Okay. So we're ready to start. And it's my pleasure to introduce this month's speaker. Dr. Pelle is a medical oncologist who specialized in the management of neuroendocrine tumors. She graduated in medicine from the University of Milan and completed her fellowship in medical oncology at the University of Bari in Italy. During her training, Dr. Pelle focused her clinical activity on the management of patients with NETs and actively contributed to clinical studies. In addition, Dr. Pelle participated in preclinical research projects, mostly centered on understanding the biology of these rare neoplasms and on developing innovative adoptive cell therapies, including CAR-T cells for the treatment of NETs. She is a member of the major neuroendocrine-orientated associations, including the North American Neuroendocrine Tumor Society, NANETS, and the European Neuroendocrine Tumor Society, ENETS. Dr. Pelle is currently working as research scientist at the Moffitt Cancer Center under the mentorship of Dr. Jonathan Strosberg. So it is my pleasure to hand over to Dr. Pelle. Thank you very much.
Thanks. Thanks for having me. It's such a pleasure and an honor to be here today. Let me share my screen. Okay. So a topic that I really love, immunotherapy in neuroendocrine tumors. As you mentioned, yes, I worked a lot on immunotherapy. And I think it's really important because neuroendocrine tumors have been considered for a long time, and they are still called tumors. And immune checkpoint inhibitors have been tested, and then they failed in the clinical setting. So it was just a shame to not see anything else going on. But recently we have seen a lot of new therapies being developed in the field. So it's an exciting topic, and I'm really, really happy to be here and talk about this. So I'm going to start saying what's immunotherapy. So generally speaking, very broadly speaking, immunotherapy is a way to treat disease by helping your body's immune system to fight better against cancer. So we all know that your immune system already fights infection and disease because it can recognize these entities as foreign entities. And the T cells usually attack the infected cells and kill them, and that prevents the infection to spread. So in general, what immunotherapy does is to basically give an extra help to find and kill cancer cells. So it's like giving your immune system a new set of tools. And that, sorry. And that's because we already have this thing that is called cancer surveillance in our body. So our immune system is always on patrol, and this is called cancer surveillance. So what happens generally is that we have a normal tissue, and then some environmental or genetic or some environmental molecules or insults, let's say, can start the carcinogenic process. So these cells acquire mutations, and then these can lead to a malignant conversion to cancer cells. So what happens generally is that the immune cells can recognize these cells as non-self, as like bad cells, and they usually eliminate these cells. It gets activated and kill the malignant cells, and then you go back to the normal state. However, sometimes what happens is that these cells the cancer cells can develop some strategies, let's say, to escape this surveillance. And then we have a phase of equilibrium where there is an equilibrium between the cells that have been, the cancer cells that are killed by the T cells or in general the immune system, and the one that can escape. But then after a while, there is this escape phase where the number of cancer cells that are able to escape the immune surveillance are way more than the others, and that's when there is the proliferation phase and the tumor progression. And that's where and when treatments like immunotherapy step in to help. So how does it work? As I said, cancer can hide from the immune system. So immunotherapy helps by activating immune cells, helping them recognize cancer, removing things that hold them back. And that's a very easy way to describe immune checkpoint inhibitors and this type of molecules. And then with the final goal is to let the immune system do its job better. There are several types of immunotherapy. We have checkpoint inhibitors, we have CAR T cells, we have cancer vaccines, we have T-cell engager, cytokine therapies, many others. So during this presentation, I'm just going to focus on the ones that have been studied or are under development for the treatment of NETs. Okay, let's start with the checkpoint inhibitors. They're super famous. Some of them really changed the uh, life expectancy of many patients with other cancers, like, for example, melanoma. Striking results with this type of tumors. How immune checkpoint inhibitors work. So immune checkpoint are like literally checkpoints, like phases in which the T cells double check and sees if they are doing the right thing, killing that cell. So it's a protective mechanism that the body has to avoid an over-inflammation. So let's say that like in a regular system, you have an infection from um, a bacteria, let's say. So your cells are infected, and then the T cells can recognize that cell as an infected cell. So they usually gets activated and try to kill that cells. But sometimes these cells that are infected are way too many, or in order to fight them all, the inflammation will be just way too much. So, or there are like other systems to, check if these cells are self. So it's a way to protect the body against like an over reaction, an over inflammation. These are called checkpoint inhibitors. There are several. There's the PD-1, PD-L1. PD-L1 is the ligand. It's expressed on the cell cells, the PD-1 on the T cells. There are others like CTLA4 and many others that have been studied. So what they do is to bind the same binding domain as the activating molecules. For example, for the CTLA4 is the CD28, and prevents the activation. So let's say this is the T cell, this is the infected cells or the tumor cells. So what happens is that through the TCR, the T cell can recognize and attack the tumor cells that is expressing something that is not normal. And what happens with the checkpoint inhibitors is that if they're active, you have that this PD-1 will bind the PD-L1 and will stop this activation. So this is a mechanism that the tumor cells have to escape the T cell recognition. So what does an immune checkpoint inhibitor does? They usually bind either PD-1 or PD-L1, most of the time the PD-1, and prevent this binding. And by doing so, they let this activation here happening. I hope that was clear. It's a complicated concept, but this is how they work. There are like so many, and so immune checkpoint inhibitors in NET. So unfortunately, we didn't have the same results as the ones that were found in melanoma, for example. In this case, the clinical significance of the PD-1, PD-L1 expression is not really clear. At least this is what we found in studies. There is a variable expression, and it's due to tumor site, tumor grade, metastatic status sometimes, but mostly also in terms of sample types, antibodies, and what's important is that overall, despite all this heterogeneity, what we found is that there is we have a higher expression of PDL1 in high grade or poorly differentiated neck and lower in well differentiated neck. And as I mentioned earlier, we had some clinical trials that tested immune checkpoint inhibitors in neuroendocrine tumors. And here are some examples. I cited like some of them. And I didn't even mention the combination ones, but for example, Keynote 158, that's pembrolizumab in well moderately differentiated NET, various sites. And then also we had avelumab, which was tested in 29 high-grade NET in this case. Also, some other were tested specifically for extrapulmonary NECs. Pembrolizumab was tested in extrapulmonary NECs. Overall, I'm not going to go into details of this, but the take-home message was that the response rate were modest overall with the monotherapy in both well-differentiated and high-differentiated nets. Although we saw some prolonged stable disease and partial response, in particular in patients with lung nets. And unfortunately, the expression of PDL1 did not consistently correlate with the response. This is I think, not, let's say, a failure. I think it's very interesting what we found because the biology of NET is very different than the one of melanoma, for example. Yeah, we know there is a low tumor mutational burden, and it's usually what triggers this recognition from the T cells to the tumor cells. So these neoantigens I was mentioning earlier that are the ones that activate the T cells are, let's say, overall less in NET, especially in the well-differentiated. So there is like a biological rationale for which we don't see a huge response using these drugs. However, I think it's very interesting because sometimes I was discussing about this with my mentor some times ago. He saw some patients that when they respond, they have a prolonged and durable response to this. So I think that there is room to study more these molecules in NET and maybe just find the right candidates. That's my personal opinion. Something that I wanted to mention was this study. It was like an international collaborative group. It was presented at ASCO, this past ASCO GI, immune checkpoint inhibitors in patients pre-treated with alkylating agents. So going back to the concept of mutational burden, alkylating agents that are currently used in the clinical practice for this type of patients with pancreatic NETs can increase the number of mutations. They work by creating new mutations. And so this study was a retrospective study, 39 patients, as I said, multicentric, more than a center involved, worldwide, I think also in Europe. And they observed that there was a better outcomes in the subgroup with a high tumor mutational burden. So perhaps immune checkpoint inhibitors may benefit alkylating agent pretreated PNETs or patients in general with a higher tumor mutational burden or mismatch repair alteration. It's an open question. It was an interesting study that I thought it was worth mentioning. And we'll see. I'm excited to see where this goes. I don't think it's a closed chapter, the immune checkpoint inhibitors yet. However, other very interesting and alternative immunotherapy approach are being developed. One of these is the CAR T cell therapy. So I think it's extremely fascinating because it's a way to elicit the immune system in a way that is completely different than the PD-1, PD-L1 checkpoint inhibitor concept. So even if you don't have that pathway activated, you still have room to use immunotherapy with CAR T cells. What are CAR T cells? CAR T are basically T cells that are taken from the patient's bloodstream. And they are transduced with a vector, which is a genetic, which is a virus that contains like a piece of DNA that encode for a gene that express this chimeric antigen. Now, the role of this chimeric antigen is to recognize a target, a tumor-associated antigen that is expressed on cancer cells. This is the concept of CAR T. So you basically take T cells, you armor them, you make them express a receptor that allows the recognition of cancer cells, and then you re-inject these cells to the patient. This has been it was a huge discovery and really worked very well in other malignancies, mostly blood malignancies, and the most famous targets, the CD19. And then many studies have been done in solid tumors, and I think this is a really innovative and new alternative way to um, give immunotherapy to patients with NETs. And a few CAR T have been developed so far for NETs. So this one is a new CAR T for the targets at CDH17. So this molecule is a cadherin. It's a molecule that is expressed on, it's a junction protein molecule that is expressed on epithelial cells of the GI tract in general. So usually this, being like a junction protein, it's usually in between cells. However, cancer cells that lose, of course, their architectural organization, they can express this on the surface and expose it to the lumen or um, the bloodstream and so on. So it was a perfect target. And this CAR T targeting this anti-CD17 has been developed at the University of UPenn. And then they did a very elegant in vivo preclinical, in preclinical study where they tested two different type of CAR T. Actually, I'm not going to go into details, but it's like a first and second generation, meaning that they added like an extra costimulatory domain to make it more powerful. So they tested a few constructs here. And what I showed in 7 different models is that this CAR T, the blue one, that is the anti-CDH17 with 2 costimulatory domains, were really powerfully able to eradicate the tumor in mice. As compared with the control, this is a control without the CDH17 or UTs, so non-transduced cells, or the other alternative CAR T with just one costimulatory domain. So this paper was published a few years ago, and now we already have the clinical trial ongoing. This drug had the IND application approved. So we have a phase 1/2 clinical trial ongoing. It's for patients with advanced GI diseases, including NETs. And the requirements is to have CDH17 positive tumors. And then, sorry, this is still ongoing. So looking forward to see the results. And then another CAR T that was developed, this was in Italy by Mauro Cives and his lab. It's an anti-somatostatin receptor CAR T. In this case, instead of targeting the cadherin, we are targeting the somatostatin receptor, which we know very well. It's a receptor that is overexpressed. We use it a lot in the clinical practice, in first-line treatment, or other type of treatment that use this receptor as a target, just like PRRT, for example. This is a mm, second generation CAR T, has a CD28 BBC. And its efficacy has been proved on three different cell lines, on actually in vitro in I think five different cell lines, and in vivo in two, bone 1 and CM, expressing the somatostatin receptor. And also here we saw that the CAR T was able to control the tumor growth as compared with the controls with the UTs or GFP only. And that's also very promising. But so far we only have these preclinical data. Okay, moving and changing completely topic and subject, let's talk about cancer vaccines. Cancer vaccine is just like a flu vaccine, but for cancer. So instead of giving the patient peptides that belong to a virus, for example, or a bacteria, we deliver peptides that belong to cancer cells, that are typical of cancer cells. And just as any other vaccine, these peptides will be presented by the antigen presenting cells that will activate the T cells, and then enhance and activate these T cells against the tumor cells that will be eventually killed. And talking about vaccine, I wanted to mention the Cervivin vaccine. This is an orphan drug that has been repurposed for metastatic NETs. It's a peptide vaccine targeting the cervivin, which is a protein expressed by NET cells. And there is a phase 1 clinical trial ongoing for this as well. We don't have data yet, but also looking forward to see more about this trial. Changing topics, let's talk about T-cell engagers. This was also very important for other diseases, especially hematological malignancies. Very famous T-cell engager, the blinatumomab, is FDA approved for CD19 positive cancers. So what bispecific T-cell engagers, in general, T-cell engagers are? Those are molecules that are most of the time antibody-based, and they basically have two arms. One that grabs the T cell, and the other one that grabs the cancer cell. So the function of these molecules is to link together tumor cells and T cells. And by doing so, the T cells are activated against the cancer cells. So I should mention that they usually bind an activating domain, like for example, CD3. So you are binding them together and activating the CD3 at the same time. The most famous important one, probably developed, is the bispecific T-cell engager that targets the somatostatin receptor 2. So this is a humanized antibody-based anti-somatostatin receptor 2 BiTE that has a domain that targets the CD3 on T cells and another domain that targets the somatostatin receptor on cancer cells. We have results, at least preliminary results, of this phase 1 clinical trial where patients with grade 1 or 2 NETs progressed after prior therapy, received a weekly infusion of the BiTE. And these are the results that we have. So it was generally well tolerated. We have some side effects that are expected with immunotherapy, CRS, for example, it's sometimes cytokine release syndrome. It's expected, but it was mostly grade 1 or 2. We had stable disease on only 26.8% of the patients. There was some immune activity, but the results were not striking. So the author suggested some like to use it in combination with other drugs, like for example checkpoint inhibitors, and also yeah, these are the latest results that we have about this study. Another type of bispecific T-cell engager is a molecule that we developed at Moffitt. So our group, what we did was to adapt the T-cell engager idea with a twist. So what we create, so as I mentioned, bispecific binds CD3 and a tumor-associated antigen, usually with a structure that like resemble an antibody. So what we did instead was to keep the same antibody-like structure for the CD3 portion and combine it with the somatostatin. So we know that the somatostatin is an hormone and has an antiproliferative effect per se on well-differentiated NET. That's why we use the somatostatin analogs like the octreotide as a first line. So what we want to have is a molecule that is different than the previous one because could potentially have a anti-proliferative effect per se, combined with a T-cell engager and tumor like T-cells activation effect. Here are some results. These are not published, so please don't post. But just to mention that we did this in collaboration with NIH, Dr. De Rivero, and Suresh. I didn't even cite myself here, but or them. I apologize for that. I just realized. But so we proved that this molecule has an anti-tumor effect on somatostatin receptor 2 positive cell lines and is specific for the somatostatin receptor, and also has an anti-tumor effect, an anti-proliferative effect per se that resembles the one of the octreotide. We have some more recent data that Dr. De Rivero just provided, proving that when we add the T cells in this preparation, we have an additive and combinatory effect, which is even more powerful than the T cells only here, or the BiTE only. Another bispecific is the DLL3. So DLL3 is so we are completely changing the type of tumors that we're exploring right now because this is more for poorly differentiated neuroendocrine tumors. So DLL3 is the delta-like ligand 3, is an inhibitory ligand in the Notch signaling pathway. Typically intracellular, but can be expressed on the surface in certain cancer, in particular in neck, including the small cell lung cancer. And there are different mechanisms by which we can target the DLL3. So now today I'm going to talk about the bispecific, obviously. And we have a study that tried and tested the activity of tarlatamab on relapsed small cell lung cancer with pretty encouraging results in terms of median overall survival. And I wanted to mention also that the efficacy and safety of this T-cell engager has been also studied with extrapulmonary neuroendocrine carcinomas. And I think that's extremely interesting, and this can be a very powerful drug that we can have very soon, hopefully. These data were presented at the last ASCO, where this group, Capdevia, showed that there was a 40% overall response rate in patients with DLL3 high. And then overall, it was well tolerated. We had some cytokine release syndrome, and that's important to mention. And also some neurotoxicity include immune effector cell-associated neurotoxicity syndrome. So CRS is extremely important for immunotherapy. It's been studied for other malignancies, for CAR-Ts or BiTEs. So it's something that we have to keep an eye on. But per se, we'll see the final results of this study. Last thing that I want to mention are the TILs. There is not a lot going on yet about tumor-infiltrating lymphocytes in neuroendocrine tumors. However, this is a very powerful tool. Also, TILs therapy worked very well for other malignancies, such as melanoma, again. So what are TILs? TILs are immune cells, mostly T cells, that have migrated into the tumors. They usually recognize the cancer as abnormal and destroy it. So if we go back to what I mentioned earlier about the immune escape, these are the same, most of the time are the same T cells that recognized the tumor at first, went there, tried to fight the tumor, and then eventually couldn't fight more because of all the inhibitory and escape mechanism that we mentioned, and stayed there in some sort of a phase of in a standby phase, like they're just not active anymore. So what the TIL therapy does is basically to take the tumor from patients and expand the T cells that are there, the resident T cells, and reinfuse these T cells in the tumor. By doing so, you kind of reactivate again these cells. And the advantage is that these cells know exactly which tumor cells they are going to fight because they've been already primed. And as I said, it worked pretty well in other malignancies like melanoma. Most of the time, TILs, like more TILs in the tumor, are associated with a stronger immune response, and they have, in general, better outcomes, has been described in the literature that applies to neuroendocrine tumors as well, where patient with, I believe it was a small bowel NET with a higher tumor TILs infiltration had overall a better outcome. So there is a rationale to pursue this type of therapy for NET. And there is, as I mentioned, there is not a lot going on yet. I wanted to mention this study that is done by Chives in Bari. He presented at a symposium. Those are not there are not data because he didn't publish yet, but he presented, and he was able to using samples from patients with pancreatic neuroendocrine tumors. And specifically, he used liver metastasis derived from patients with neuroendocrine tumors. What he did was to collect the tumor and, of course, the blood, the PBMC. And from the tumor, he was able to successfully grow TILs and also tumoroids. And then after combining them, he saw that these TILs were reactive against the tumors. So now he has a whole phase of TCR profiling and so going on. So this is also a really exciting field. Really looking forward to see which one are the next data that he's going to publish. And I believe that's it. So just to conclusions is that conventional immune checkpoint inhibitors showed limited efficacy both in NET and NEC. However, I think it's not a closed chapter yet. There is probably, my opinion, still room to study which one is the best patient population that can actually benefit from this treatment. Other targets are coming up. DLL3 targeted immunotherapy, for example, demonstrated early signs of activity in poor differentiated NECs. We have other very intriguing drugs. CAR T cell therapy. We saw that one of these is already in clinical trial. We have some other bispecific T cell engager also in early stage. I mentioned the TILs. So there is a lot going on in the immunotherapy field. And really, as I say, looking forward to see what's going to happen in the next couple of years. Thank you.
That was amazing. Thank you so much. That's so interesting. So questions, and we have one. Sonia, would you like to ask your question? Sonia?
Yeah, sorry, I don't have a question.
Oh, you had your hand up.
Did I? That was an
Yes.
error.
Oh,
Sorry.
okay. Does anyone else have any questions?
I have a question about DL3. This is Renata.
Hi, nice to see you again.
Yeah, nice to see you again too. Um, you know, we were testing the expression DL3, and usually you do not publish negative results, right? But our knowledge was that, of course, none of neuroendocrine cell lines, which we have, BON, QGP, NT3, do not express DL3. And we have also quite a big collection of TMAs, probably like 150 patients, and also testing them for, those are mainly pancreatic neuroendocrine tumors, and also testing them for DL3. We were kind of disappointed. We didn't see a lot of positivity. We
Yeah.
had quite a few grade 3 and NECs, but also none of them really expressed DLL3. And there is also a recent publication from February this year that actually, besides prostate neuroendocrine cancer and pulmonary neuroendocrine, others do not really express DLL3. So I'm just wondering, what is your
So I believe that in this study, now I don't remember on top of my mind, but of course they had to express in the inclusion criteria DLL3. And then I believe that in these patients that they presented at ASCO, they screened the patient and they had to be positive, and positive was considered more than 50% of the cells. I think I found a slide. I can share it.
And
Um,
those are not prostate, right? And not pulmonary. Those are
those
different.
are, yes. So of course you have to, I agree with you. And it's extremely important to select the patient population. I think this is what they presented. You can easily find the abstract. I'm sure it was presented at ASCO, but this is what they said, and then the expression had to be. They defined a high expression as more than 50% in immunohistochemistry, and what they showed, which makes sense with, and it's aligned with what you just said, is that this was whenever the DLL3 was low, we had basically no response as opposed to the high. So yeah, going back to your point, you have obviously a point. Not all of them express the
Sure.
DLL3, yes, but if they do, there is room for
Of
this
course, yes.
to
Yeah.
work.
So maybe those
So
patients.
it's probably going to be something, in my opinion, similar to what we do with the PRRT, where we'll have to screen, of course, first the patient for the expression
SSTR too.
of the
Yes.
SSTR, and then that will make them eligible.
Yeah, I was just curious, what is the real percentage of DL3
Yeah.
positive? Because what we found is very small. However, even with the small, it is quite important because maybe those DL3 patients positive, SSTR2 negative. So it might be the only option, for
And
that. Yes.
yes, and it could be because we are talking mostly about poorly differentiated here,
Yeah.
which most of
So
the time,
even if this is 10%, this is
correct,
still important. Yeah.
correct.
However, it's small. And, probably if you want to test in the cell lines, yeah, we did not really confirm DL3 positivity in a cell line. So probably the only model would be to have transfected and overexpression, cell line with DL3. Okay. Yes, great presentation.
So
Yes, thank you, Eleanora, for this wonderful presentation. It's really nice of you to kind of lay out the different strategy because a lot of us are not immunologists and we're beginning to learn about this. But I really enjoy your presentation and how you divide the different section to make it really much more clear for us for understanding. But I have a question regarding, the CAR T cell versus like the T cell engager approach. And since I'm not an immunologist, I'm just wondering, like, what would you say about how can you comment about the toxicity of these two different approaches? Is one more prone to having more side effects or something like that?
that is a great question. The experience that we have is based on the hematological malignancies, obviously. So with the blinatumomab or the anti-CD19 CAR T, there are other CAR Ts. I will say that, in my opinion, they are very similar in terms of toxicity profile. The most important one is the cytokine release syndrome. And yeah, these are immune related side effects that derive basically from this hyperactivation of the T cells. So we have this cytokine storm, and that can happen just by hyperactivating T cells through a CAR T or through a CD3 engager. Now, there are ways to kind of fine-tune this cytokine release. And I know there is a lot of work going on to try to have CAR Ts that are still able to kill, but with less toxicity, with less cytokine release. Other type of T cells, for example, the gamma delta instead of the alpha beta. All the work that I showed was done with alpha beta T cells, which is a type of TCR. There are others. I'm not entirely sure of which one are the safety effect. I know that there are like some gamma delta CAR T study ongoing. I'm not entirely sure of which one are the safety profile of these cells. Or for bispecific, for example, another way is to change the type of CD3. We have different ways and different antibodies that can target the CD3. So some of them are more tight, let's say, to the CD3. So that gives like a more powerful effect sometimes. But overall, I would say they are similar and very and they changed based on the type of compound that you're using, the different type of bite, the different type of CAR T.
Well, thank you. Thank you for helping us to clarify this because, yeah, I think there's a lot of like investigator, actually like immunologists, really like trying to actually use their expertise to help the neuroendocrine tumor fields. But, for me as someone who's like not immunologist, I don't really understand. But,
That was a
thank you
great
for
question.
trying to really explain this in a very nice way. Thank you.
Of course.
I have one more technical question. So recently, NIH suggested to decrease amount of animals in the studies. So what we are developing kind of reactivating because we used to work on bioreactors, so on explant neuroendocrine tumors. And after a few years, probably we will go back to this model. And what would be advantage that in this model, actually, we are developing even metastatic. So this will be another bioreactor. And we want to insert explant from the liver. And I was wondering that this will be a really great model to really test immunotherapy. First, we have to really prove that this model is working as for metastasis. But I think the main advantage will be that in the nude mice, you cannot really test immunotherapy. So finally, my question is, from which of those which you described would you suggest to test in those bioreactors?
Yeah, this is a great point. And yeah, I believe that there is like a lot of limitations, as you mentioned, with animal models, especially when you're working on immunotherapy. Because what we do sometimes with CAR T is just to deliver the CAR T in nude mice. So we are just seeing the effect of the T cells that we are giving to the mouse, but really like skipping all the immune microenvironment that is not there, obviously. So I think that there is like a lot of potential by using these different tools, and that would apply to CAR T because, as I say, they can their activity can be also modulated by the immune environment. Treating a solid tumor is way different than treating a blood malignancies. This blood is like
Yeah.
floating, so it's not like a tumor environment. Solid tumors, it's not just the tumor cells, it's all what's in there. Can be fibroblast, CAF, other immune cells there that really, and there are like plenty of studies that describe how these other cells can switch and modulate the activity of CAR T or other T cells. So going back to the short answer, it's a great tool, and I really think that there should be some investment in trying to develop these that can give. Well, we have other ways to we can have humanized mice, for example. There are other ways that we currently use to try to answer this question and have a system that resemble the what happens in a human body the best way that we could. But yeah, that would be a great alternative. And I know that the NIH, they also have something similar. And Heidi's here. I just saw her name, and I just want to say thank you again for their amazing support. Hi, Heidi. Oh my God, so nice to see you. Their help was and support was amazing. I showed the data that they provided. And so, yeah, it was a team effort. They have the organoids. So going back to the system, it was great because instead of the mice, we used the organoids, the patient derived, which is even like probably a better model because it's well differentiated and very similar to what we see in a patient.
Yes, great. Yeah, thank you.
Okay, we've probably got time for one more quick question. If someone, Ilaria, yeah?
Yes. Hi.
Hello.
Eleanora. Very nice talk. Thank you. I just echo Paul that I'm not an immunologist, so for me it was very interesting to listen to your talk. And exactly, as a non-immunologist, I would say that yet, but of course we have to wait for the next result. In NET, we don't have extremely successful results with immunotherapy. And I was wondering, which are the most common reason for that? What do you think are the reason for that? And what are the resistant mechanisms that you see in these therapies? Just the lack of expression of the target for sure, or is just the immune cells which are a bit, I don't know, lazy, or we all know all the tumors, so yeah.
I was debating if I wanted or not to include a slide about the immune environment in NET specifically. And then I said that's too much, but then I should have had probably. It's very heterogeneous. You know that NET is one disease, but really it's like so many different diseases. We have poorly differentiated and well differentiated, and also the primary side plays a role, right? Small bowel nets are very fibrotic, and they have a different cell population, let's say, compared to the pancreatic ones and also to the metastatic sites. So the literature showed and proved that there is tumor infiltration. We proved also that there is a better response in or survival prognosis, sorry, associated with a higher T cell infiltration. And we also proved, the literature showed that there are in the circulation, like peripheral blood of patients, there are T cells that are specific for neoantigens or antigen specific for the tumor. Chromogranin A is one example. So there is immune recognition. There are cells that are there ready to fight. However, I believe that what we've used, like specifically the checkpoint inhibitors, are targeting like one specific aspect that is not probably the primary one in NET. We have Tregs, for example, FOXP3 positive cells. So these Tregs modulate the immune response in a way that can be different than the one that we're trying to target. So maybe it's just because we are trying we're looking for something that works for like one for everything, and that might not be the case for NET. We might need to be more specific and look more at the type of NET that we are trying to target and have a different type of immunotherapy specific for each different stage or each different type, each different grade. And what's exciting is that that's what's happening. Lots of studies about immune microenvironment are like revealing which one is the status, and that will help us to find a multi-tailored type of treatment. So yeah, I think that's my answer. It could be that we are just starting digging in the immunotherapy field for NETs, and I really have a hope that we'll find like a better way to target these cells.
It's like a personalized immunotherapy.
Yes, more specific for the type of NET that you are treating. And for the also stage of the tumor, for example, there are like cancer vaccines that I mentioned. I think that they can be very powerful in a adjuvant setting, for example, or even for CAR-T, for solid tumors. I think that there is room for CAR-T in an adjuvant setting. They can also be used, of course, in a metastatic setting, but I think we just need to refine a little bit what we want to accomplish, and I think there is room for immunotherapy in NET.
Thank you.
Oh, is there anyone else who's got a very quick question? We have 4 minutes. No? No. Okay, well, thank you so much. It's a really exciting field of research, I think. I mean, there's so much potential there. And thank you for simplifying things for us. Even I found it easy to follow, so fantastic. So thank you everyone for coming. And I'm really looking forward to seeing those of you who are coming to UK in a couple of weeks. Very exciting. The next meeting is on the 25th of September. And very thanks to Poe for organising our speaker for September. So news of that coming very soon. And thank you so much for coming. And we will see you all next month, hopefully. So thanks a lot, and we'll see you all soon. Thank you.
Thank you.
Thanks. Bye-bye.
Hi, thank you.